The waiting room.
We do.
All right, welcome, welcome. So great to see you all today. This is the HCBS Rate Determination Forum number 3. This presentation focuses on therapeutic interventions and assistive technology for sections 18, 19, 20, 21, 29, and 40. My name is Kristen Gore, and I am a senior consultant with Public Consulting Group. I am the project manager of this initiative. PCG is a public sector focused management consulting firm that assists public agencies in better serving their targeted populations, specifically human services, health, education, and technology consulting. In particular, many of our projects are focused on rate determinations, much like this work that we are presenting today in collaboration with MaineCare. So for our agenda today, we're going to start out with welcome and reminders. We'll do some introductions, discuss rate reform process and review. Then we'll jump into the draft rate setting methodology and the model inputs. Then we'll talk through each of the draft rate recommendations and close out with next steps and Q&A. For this slide, I'll pass it over to Kristen Merrill.
Thanks, Kristen. Hi, everyone. Good afternoon. I'm Kristen Merrill. I'm the Associate Director of Program Implementation within the Office of MaineCare Services. And I just want to start off by saying a big thank you to everyone for their time and participation today. We will be diving into the MaineCare rate reform process and draft recommendations in just a few minutes. But before we do that, I just wanted to take a moment to touch briefly on a few different things. So the first is that this was a very large effort and has taken a lot of time. And as many of you know, this effort overall touched on about 9 different sections of policy within the MaineCare Benefits Manual and close to 130 distinct services. These draft rates will be presented across 3 different presentations. Today is the third and final. Part of the goal of MaineCare rate reform alignment is alignment across sections of policy, or to say that differently, it's really an effort to create payment equity where the same or similar services are under different sections, but the rates are aligned. And so this can result in draft rates that recommend increases or decreases across various sections. There was and will continue to be consideration of state and federal requirements. This includes things like 22 MRS 7402, which is the Essential Support Worker Reimbursement Statute, which does direct the department to reimburse at least 125% of minimum wage for essential support workers. And next slide, please. Thank you. So please also note that while draft rates are developed using inflation through January 2027, we still do not have an implementation timeframe because of various factors or actions required to implement changes. And so sometimes these additional steps can limit implementation timelines or implementation in general. So along with the formal rate reform process, there can be other steps required by the department in order to implement any rate recommendations. And this can include things like budgetary asks and approval or appropriations from the Maine state legislature. It can require rulemaking in accordance with the Maine Administrative Procedure Act process, or the MAPA process, as some of you might know it. Can also require federal authority for changes, which can include approval of state plan amendments and 1915C home and community-based waiver amendments, which do get submitted to the Centers for Medicare and Medicaid Services, and they authorize those. And just a note regarding those 1915C home and community-based waivers, those do require cost neutrality. And this just means that the average cost of caring for a person in a home or a community setting cannot exceed what the government would have spent if the same person were placed in an institution like a nursing home or other facility. And so just keep in mind that some rates have not been updated in many years. And so those rates may have older models or have been implemented through legislative directives. So it's not always clear how they were developed or and when or if they were considered considering things like the minimum wage changes that went into effect several years ago. So these draft rates do update whole rates and all assumptions, not just wage-related data. And that's based on a combination of data submitted to the department by participants and gathered from external sources. And so final rates may change based on further review and consideration of any input received through the comment phase of this rate determination. And so we really appreciate everyone's time and input so far, but also are really looking forward to additional input through the next phase of this project. And with that, I will pass it over to Jess to start our introductions.
Okay. Thank you, Kristen. Next slide, please. So here's a slide that lists everybody who's working behind the scenes and working with PCG for the last 2 years on these codes. So myself, I work in delivery system reform, and I've been the lead on this project. Kristen Merrill, who just introduced herself. I have Heather Bengalis, who's the acting LTSS manager at Maine Care. Megan Brooks, who's the LTSS policy writer at Maine Care. Dwayne Parsons, who's the senior manager of reimbursement and fiscal management for Maine Care. And we have Megan Scott, who is helping us on the meeting today, and she's the legislative and reform coordinator for Maine Care. Nicole Rooney, LTSS manager from ODES, and Derek Fales, also from ODES, the associate director of developmental disabilities and brain injury services. Thank you. Next slide, and I'll hand this over to Kristen.
All right, thanks, Jess. So I'll go ahead and do a brief introduction of the PCG team. Again, I'm Kristen Gore. I'm a senior consultant at PCG and the project manager for this rate determination project. With me today, I have Rhonda Kern-Strauser, who is a senior advisor, Jeremy Thomas, who's a senior consultant, Erica Altman, a business analyst, and then not with us today is Megan Morris, Joe Carbo, and Luke Lofgren. So I'll pass it back to you, Jess.
Okay, thank you. So I'm going to take a couple of minutes and talk about rate reform process and give you kind of a high-level overview in case people have not been able to be a part of this process before. First slide, please. Or next slide, please. So as a high level, the rate reform process is standalone section of Maine law that is Title 22 MRS 3173-J, which was enacted in 2022, which enabled the following things. So at a high level, what it has us do is set schedule for regular rate review and adjustment. So it's ensuring that everybody's rates are reviewed on an ongoing schedule, and we plan that out ahead of time and make sure that all rates are being looked at. The second thing it does is it ensures for a review of relevant state and national data that informs the rates, amounts, and payment models. So a little more specifically for that is if we were going to do some benchmarking. And so all Maine Care services and rates in this study are compared to their closest corresponding Medicare codes, and we have the goal of aligning those with reimbursement rates with the programs. And what we considered when we were looking if we could align to Medicare codes were asking ourselves some questions. Does the service description between Maine Care and Medicare align? Does the cost structure between Maine Care and Medicare align? Many of the Maine Care services and rates cannot be aligned that closely. And then, therefore, what we do is we come up with a rate model and a different methodology, and then we'll be going over that later. So that's a basic level of like what we do, how we benchmark, or if we decide if we have to do a rate study and do a methodology. Number 3, what it does is it allows for a clear and transparent process of a rate determination. And so on the next slide, I'll go over the different steps that this particular study has went through. But it's why we're all here today. We're happy to have you here, engaged in our process and seeing how we came up with these rates and methodology, and would love your involvement and feedback. The fourth part of it is the Maine Care Advisory Committee, which it ensures the program remains effective, efficient, and responsive to the needs of its beneficiaries. You'll also hear this group called the MAC. Then the fifth thing that the new law allowed was a technical advisory panel, which there is a group of people who are identified and they meet as appropriate and they discuss technical matters as needed. And you'll hear that referred to as the TAP. Next slide, please. So, as I promised, on this slide, we talk about this specific rate determination and the steps that we've taken. So it started in June of 2024 when an initiation notice was sent out. Then there was a kickoff meeting held on August 28th, 2024. And we did a series of interested party engagement, which started in September of 2024 and ended in October of 2024. Then we had a period of time in which surveys were filled out between October 22nd and November 22nd. And then here we are today and last Friday and last Thursday, breaking this large services we're doing into 3 separate groups. And then after this meeting, so we are open for comments during this meeting. If you have any official comments at the end, or if you have till July 13th to think of, if there's anything that you would like to submit for comments or feedback on this. Then what happens after July 13th is the department reviews all the feedback we receive, and then we consolidate those comments where they're alike, and then we post the written response to comments on the rate reform website. And then finally, there'll be a rate finalization. I just wanted to say before we go to the next slide that I will be posting housekeeping information in the chat. And I'll also post some links in the chat, so that will help you as we go on. And then we'll post it again maybe at the end if we've got too much correspondence in the chat that it kind of gets lost. So thank you for being with us today. And next slide, I'm going to Rhonda. Oops, I forgot. This was my slide too. Sorry. This just basically talks about the 3 meetings that we've already talked about, and today being the last meeting, and the 2 types of services we're going over today. Now you can have the presentation, Rhonda.
Thanks, Jessica. We're going to talk about the draft rate setting methodology and what are those inputs. Next slide, please. So want to start talking off about the independent draft rate model approach and how we used actual provider costs and multiple different data sources that we've lumped together in large buckets below that we're going to talk about a little bit into that final draft rate model. So each of these inputs included like staff wages or benefits, staffing levels, service levels, time to complete service, including things like documentation. And we'll talk about travel as well, transportation. So first off, started looking at the state policies, rules, and laws within the main care benefit manual. We also looked at national resources such as BLS wage data, IRS mileage rates, provider and interested party input, as just mentioned. And some of you I know were part of those discussions or completed a survey because we did have a provider survey as well as interested party outreach. And then we also looked at some other sources like Medicare benchmarking and peer state benchmarking. Next slide, please. So within this, let's talk a little bit about how this was broken down a little bit more for the structure of the model. We used different high-level steps to calculate each service rate, and each group rate was calculated by dividing the number of participants by the hourly individual rate. So to do this, we looked at personnel cost, which was direct service staff salary, direct service staff tax and fringe benefits, and then a productivity adjustment. We added that on to non-personnel costs such as program support, overhead, and mileage. And then that gave us a total program cost that we identified, we took that total program cost, divided by the number of participants, and that's how we got that rate model that we've identified. Lastly, I do want to call out that a 10% incentive was added for all work group or all group services. Jeremy will talk a little bit more about that in some of the modeling in the future slides. Next slide, please. So the rate model structure, we use benchmarks for a variety of different variables within each benchmark. We'll talk a little bit about these. So first off is the direct service staff wage. That benchmark was variable because different professions are utilized to perform the service. So an RN, if it was matching, we would use that versus a home health aide or something. So the source we utilized for that was BLS. And I do want to call out that May 2024 BLS data is what our model was based on. Next is fringe and benefits. We used a benchmark of 946 plus 8.15%. That is a combination of the BLS December 2024 data as well as the main tax. So we included those specific main payroll related taxes in there. Non-billable percent, we utilized a benchmark of 25%, and this is based on estimates that we determined from different sources of information. Travel time, we determined a 10% benchmark. Overall overhead cost is 15% benchmark, and that is from the CMS de minimis rate. That's where that came from. And then the program support, 10% was the benchmark we utilized. That is, again, a baseline estimate. The assumption is based on 4 hours of direct support per week. And then the mileage cost is 70 cents as the benchmark, and that's the federal mileage rate. I also do want to call out that we looked within this mileage cost, the cost of 1 hour traveling multiplied by the time spent traveling and the average mile per hour. So that's the different benchmarks we utilized in the rates, which Jeremy will definitely talk more about. Next slide, please. So let's kind of break down from the draft rate model an example and how we came with those numbers. So if you look at lines 1 through 5, that is related to direct service staff costs. The next 2 lines are administrative and program costs that we added on. Then the 8th line is miles driven, and that gives us a total cost. And then I'll talk a little bit about that final draft rate per unit. So within the first line, that's the draft service staff hourly wage. In this example, it's $42.38. There is not an adjustment factor. And again, this is based on 2024 BLS data for this example. We then looked at the employee benefit rate. The cost per hour of service is $12.91. This adjustment factor is 946 plus 8.15% to give us this rate. We then get a total compensation of $55.30. Once we get that, we looked at that non-billable and travel adjustment. That is 1.54 for this particular example. The adjustment factor is 35%. As identified here, there is 35% productivity adjustment. So for every 40 hours worked, 26 is direct billable time, 4 hours travel, and 10 is an additional non-billable time. We'll also note that in some of the examples or the rate models you see in the future, that 1.5% is like 54% of the total. So Jeremy will talk also a little bit about that as well. And then that gives us a direct staff cost per billable hour of $85.07. So that gives us that total. So then we bring in that administrative and program cost on top of that. So 1134, there's that adjustment factor we talked about of that national benchmark of 10%. The indirect cost per billable hour was 1701 in this particular example, and a 15% adjustment factor was applied there. And then vehicle mileage cost is 507, and that there's not an adjustment factor there. That gives you a total cost of 118.50 in this example. Once we get that total, if that is per service or if that is a per unit, we then took that and divided that out. So 118.50 divided by 4 for a 15-minute unit, that gives you 29.63 per unit for that draft rate model. So that's kind of how we came up with that. And just wanted to kind of break it down a little bit more. So Jeremy will show you those explicit draft rate models as he gets through his portion in the future. Next slide, please. So wage assumptions. A couple of things want to point out here. So we did do a provider survey, and as you can see here in the green, we looked at ask about different position types, like a CNA or a registered nurse or OTA or something like that. And we asked about what those rates were. We got some average reported, as you can see listed here. However, the number of responses we had were lower. So we wanted to make sure that we looked at the wage assumptions and included in the rate models higher wages than was reported through the provider survey, because we wanted to make sure it was well represented. So with that being said, you can see on the right side of the screen, the median 2024 BLS data. That's what we utilized in the modeling. And you can see the difference between what was provided in the provider survey versus what the BLS data identifies. And like I said, we went with that in the modeling. Next slide, please. Couple of things regarding BLS data and certainly with our modeling. So we use this to determine the appropriate wage for each position. This is across industry median wages. Were used when available. And again, below, we'll talk a little bit about this, about blending. So if you recall previously, I mentioned we identified BLS data and who would be doing the service. Of course, if it was an RN, it would match directly to an RN. However, there are certain services that require different positions that will be providing that service. So what we did is we created a blended wage. In this example here, this is a 97192 for a therapeutic intervention for cognitive function. The position titles that we used here is therapy plus therapy assistant blend. And we went to the BLS and identified occupational therapist, occupational therapy assistants, and physical therapist. We then assigned a weighting to each one of those positions. And then brought in that median wage for each position, and then took that and calculated it into a average weighted hourly wage. And in this example, it's $42.90. We then utilized that within the model in different places as well when we were creating the draft rates. Next slide, please. This, again, just talks a little bit more about each position and the blended positions, in which you'll see in the draft rate models. I believe, yes, this is in the appendix. So first off, the personal support aid, that included home health and personal care aides. We give you in the next column there the BLS code, as well as what the total hourly wage was that we utilized. And then again, what percent, and then the BLS median hourly wage. So for all of these positions, 100% are matched directly to the services being performed. I don't see any blends in here right now, but there may be some as Jeremy will talk about a little bit more in the future. But the positions we utilized, personal support aide, speech language pathologist, speech language pathology assistant, physical therapist, physical therapy assistant, occupational therapist, and occupational therapist assistant. So these are the wages you'll see in there based on the BLS. Next slide, please. Again, talking about the positions, here are some of the blends that are involved in the different codes here. So the physical therapist, physical therapy assistant blend, we utilized those two positions. We gave it a 50% equal weight, identified the median hourly wage, and then we got that total hourly blended rate or wage of $50 or $40.13. Occupational therapist and occupational therapist assistant blend. We did the same thing there, and that was a 50-50 blend, identified the wage, and we utilized a total hourly wage of $36.72. The assistive technology telemonitoring blend. I can say that when we were looking at this, we did talk to providers to try to understand who and what would be performed and who would be doing this. So we identified registered nurse practitioners, and physician assistants. The weighted blends here are 60% for the RN and 20% each for the other two. This weighted blend for the hourly wage is $52.38. And then the communication aids blend, again, we did have a conversation with providers as well to get an understanding of this. We assigned the home health aides, personal care aides, healthcare support, occupation, and social and community manager here in this blend, 33.3% for each. It came up with a total hourly blend wage of $26.15. Next slide, please. Fringe and benefits, again, the fixed cost is what we utilize for paid leave. That amount applied with inflation of 431. Insurance, we included life, health, and disability. That's a fixed amount that we utilized in the modeling with an inflation applied of 354. Retirement and savings, we utilized a fixed amount with an inflation of $1.60 added. And then legally required benefits like the main payroll tax, that was proportionate, which was that 8.15%. So we did account for these things in the model. And here is some of those different pieces we added in. Next slide, please. So inflationary factors, inflation is applied to all developed rates in order to account for changes in the economic climate. These factors were calculated using the last 12 months of inflationary data. So we considered the rate implementation year of January of 2027 and implied an inflation factor of 2.68% to all current rate models based on the most recent 12 months of inflationary data available in the BLS data. So as you can see on the left side, the rate application for 2027 is at 108.25, 28, of course, is 111.15, and so forth on down with that inflation rate as applicable. Next slide, please. I will turn it over to Jeremy. He's going to talk with you about the draft rate recommendations and really pull those pieces together to show you what the drafts are right now.
Thank you so much, Rhonda. All right, so let's switch over to slides. So like Rhonda mentioned, I'm going to go over the actual rate recommendations. So here is an example. We're going to start with the first 5 slides covering our benchmark to Medicare rates, right? So continuing to make sure we're clear that a lot of these changes that have happened for these rates happened for 2 separate systems. First is if we identified an equivalent code in Medicare, we wanted to make sure that we benchmarked that to 72.4% of the benchmark rates. So these changes in these first few slides are due to the changes to the Medicare rates. And so that is primarily the focus here. So, and then once we get into the rate models, we'll go over those. We'll look at a couple of the codes, but again, at the very end, we will circle back around to talk about what the changes are that actually made that difference. So looking here at the physical therapy visit rates, you'll see it's quite a mixed story. The point being that this is really, again, benchmarking to those Medicare rates. So you'll see there is a consistent rate that is being proposed across the board. So this is level setting a lot of those. So this rate, for example, would be 24.14. Some of those rates went up, some of those rates went down, but it really was about making sure that where there's consistent activity happening, that we're doing that effectively in these models. Next slide, please. Continuing the story on with the occupational therapy visits. So these are the G0, 152, 153, and then the maintenance for speech therapy. Oh, so occupational therapy and speech therapy. You can see here that difference in the type of rate. So starting with that 15 minutes for occupational therapy, then that 73 for speech therapy. Again, really level setting those, and those often changed quite a bit here. You can see in those home health service visits for speech therapy. Next slide. Continuing on, again, level setting these, you'll see that they're very consistent rates. So 24.14 for that occupational, physical, and speech therapy. All the way down. Again, it really just the changes compared to what the original rate was. So those rates that were already a little bit higher have a slightly lower increase on these rates, while others might have a more significant increase as benchmarked to Medicare, excuse me. Next slide. Continuing, this is a fairly similar story. We do have that non-traditional communication assessment down at the bottom, but overall, really just aligning to those Medicare benchmarks, physical therapy, occupational therapy, speech, and non-traditional communication. Next slide. All right, so continuing on that story, in that non-traditional communication, if you were to compare those two, you can see that there's a similar story going on. Assistive technology assessment all the way down, more moderate changes, but for the most part, still benchmarking up to that rate as compared to the current to make sure that we're keeping up with the times. Next slide. All right, so here we're getting into our rates that were developed based off that methodology that we got from Rhonda earlier. So looking at these are the personal emergency response system installation and testing and the service fees, right? So providers who currently bill to Section 19 were surveyed via email to identify vendors that the patient population that they procure these services from. So the average between all noted vendors' median pricing plans was found to inform the customary charge limits for the installation and testing, as well as the service fee rates for the PERS services. So realistically, this is based foundationally on the survey that we have completed. And this is a representation of those costs overall. Next slide. All right, so continuing on, we have the physical therapy visit, the occupational therapy visit, and the home therapy visit. These have a little bit of a mixed bag in story, primarily focused on both changes to the wages for these positions overall. There has been some compression in the market on wages overall, but we're also seeing potentially some how long did it take to do this service shift. So overall, I will show you in the model exactly where you can track those in the appendix here in a few moments. But primary point being that the primary goal is that we are aligning these services to ensure that all the components that can be compared are consistent amongst each other. Next slide, please. Continuing the story, non-traditional communication consultation, physical therapy consultation. So all of our consultations right here, those have very significant increases, primarily around the time frame of how long it takes, but also understanding exactly how these all work together in a system. So really creating a more consistent cluster based off of the wages for each position. Next slide. Sometimes I worry, did we move the next slide?
We did. It's
Good.
Oh,
section 21 instead of 20. So same
consistent. Sorry, my
services.
apologies. I'm the finance and data guy, so sometimes I get a little confused. But overall, we're seeing same story overall. Again, making that consistency amongst all these different policy sections is a part of the process. So it's a good representation of how consistent they are. Next slide. All right. So in this one for the section policy of section 40 policy services of physical therapy in a home health setting, the physical therapy assistant in a home health setting, occupational therapist in a home health setting, and an occupational therapist assistant in a home health setting all have some slight changes overall to these rates. And again, I will show you in each of these rates exactly how you can trace where that change may or may not have happened. But overall, again, making a more consistent clustering of these services based off of those wages as compared to the other service categories. So this is really a comparison of 40 versus those others that we were previously looking at. So they are still consistent among each other. Next slide. All right, and then therapeutic intervention services here. So speech language pathologist in a home health setting, that 2963, again, consistent with what we've put above in the previous sections. And so really any changes here are to match to that overall structure and ensuring that like policies get like costs. All right. So technology services. So the remote monitoring monthly fee, the personal emergency response system installation and testing, and PERS service fee all have gone up pretty significantly overall, but primarily focused on ensuring that they are keeping up with the needs of the service. So there was quite a bit of conversation about these to make sure that they were truly at the level that they need to be, and we believe that this meets that need. Next slide. All right, continuing that, the telemonitoring of a patient in their home and communication aids. Continuing on with this story to make sure we're benchmarking, you can see that that previous rate was really low, but now it's more in line with those other services as we've mentioned and has been rebalanced to meet that need. And you'll see that the telemonitoring was already pretty close, so wasn't a huge big shift overall there. All right. So just to talk a little bit about the decrease explanation. So this is all the therapeutic interventions. We will come back to look at some of the models and show you exactly how to research these changes overall. But again, the point being that we're really trying to match 19 and 40, sections 19 and section 40 to ensure that the process is equal. Having a disjointed market where one side is getting quite a bit more than the other is not helpful to anybody. So really making sure that we're paying the right price for the right service. And so we're really trying to lean into that consistency for rate methodology and equity across all policy platforms. So keeping that consistent. And then one more slide, I think. So, one more of these. So again, reminding you that those changes that went down for the policies under the main care benchmark really are in line with 22 MRS 33173J, which requires the main care determine a benchmark to the Medicare rate as available, and we did that. All right, so before we move on to next steps, I'm going to steal the screen for just a moment and show you all the appendix. So the appendix is part of the project materials and will be made available to all participants that need it. The primary goal here is to clarify and to provide you with every tool possible for the most thorough comment you can possibly put together, because we really do want those comments. We want to understand how you're perceiving these rates and the components. So if you look over here, we have our appendix open. It gives you a brief explanation. You can see which services. So if you get all three, make sure you're looking in the right appendix for the right type of service if you're looking in the future, because there's three different versions of this appendix. But what you'll then see is that each appendix will come with all of the models listed within that section of policy and within those types of programs. First, though, what you'll notice is that each model will be listed here in this same format. They're exactly the same. It's worth noting that it'll have the procedure code, the modifier, revenue code, where the section of policy is, what position was used in that base wage blend, and then what the unit is. So real quick though, before we go into any individual model, let's say we want to look at that PT, PTA blend. We want to know how those were developed. You can go all the way down to the bottom, and we've listed all of the wage blends. It's also in the PowerPoint that we went over, but if you want to have it all in one document, you can come down here. You can look at this PT, PTA blend. You recognize, oh, okay, we use the physical therapist. That's consistent with what we would expect, and the assistant's wages. It's 50-50. We would assume that it can be half the time it's a PTA, half the time PT. So that is then going to be the rate to be used. So using that blend, we then use that as the basis for the model. So continuing with this model, we pull that up. We have that base hourly wage as noted. And now you can see and trace down this right side all the calculations that are needed to be able to ensure that we did the work correctly, which we did. So direct service staff, you'll have that wage there. You add on your fringe benefits, which is $12.73. That gets your total compensation cost for that singular position. You then want to multiply that times 54% to get your unbillable time. So that's all that additional stuff that happens outside of that specific service delivery visit. And so we want to make sure. So really for that hour, we're paying $81.31 for that hour. Just for that person. But then you also want to pay for program support and all that indirect cost at the organization, HRIT, all that jazz. That gets you all the way up, and the vehicle mileage cost, that gets you up all the way to $113.51 for the total cost. This is per visit, so that is the total cost overall for that rate. If we do have a rate that does a non-per visit, what you can find out down here is that the total cost is then split. So for this one, this is the non-traditional communication consultation, which is a 15-minute rate. So you can see that that total hourly cost of $118.50 is then divided by 4 to get you your 15-minute rate. These services, none of these services have group services, but if you are also in one of the service categories that have group services, you'll note that beyond that step to get you to the 15 minutes, we'll also then split it by the total number of youth in that service for that time frame, and then add an additional 10%. So overall, if you'd like more information about that, you can go watch our previous recordings for our last session, but realistically, it's pretty clear overall. All right, I'm going to stop there for now, though. I'm going to pass it back over for Q&A, but I do want to make sure that you all know that I'm here and really excited to go over any specific model that you may want in the meantime while we're doing the Q&A.
Okay, thank you, Jeremy. I'm going to go over next steps and Q&A. If next steps, thank you. So we're aiming to have everything posted from today's presentation onto our rate reform website by tomorrow, end of day. Might be there sooner, and the last 2 presentations and all their material and the notices are posted on the rate reform website. We are accepting comments today in the presentation, and then written comments through to July 13th. And you can submit those comments to the ratereform.oms@maine.gov. I'm also going to post that into the chat. All comments will be reviewed and summarized, as I had stated earlier, and then we will have a written response to that will be posted and tell you if we did incorporate the rate, why we did, how, and if we couldn't and why. And then we will make changes as we deem appropriate. We really do want, so this is your reminder, I know I've said it, but we really do want detailed review of this, comments, feedback back on these draft rates, so that at the end, once we receive all the feedback, it might be a higher rate, it might be the same, unchanged. We don't know, but we definitely need the feedback in order to see if we need to make some adjustments to those rates. I did post the rate reform website, which is where you'll access all of these in the chat. Reminder of the comment due dates, and also the email for you to respond. And while I'm going to go through the next slide on how you can make comments or ask questions today, right now, live, be thinking if there are specific models you'd like Jeremy to go over, and he will go over that in the appendix or in the PowerPoint, whichever you'd like. So next slide, please. Please, if you have a question, please raise your virtual hand, and you will be able to do that by hitting the reactions button at the bottom of your screen. We'll call on people in the order in which the hands are raised. When you do come off of mute, please state your name, your organization, and try to limit your comments to several minutes. You will have time to come back in again and go in the queue if you want. I did not see anyone on the phone, so I won't go over those directions. Also, you can do Alt-Y on your keyboard to raise your hand. So a reminder at the bottom about the official comment and the link, and you can copy and paste those from the chat, I believe. If anybody has any questions, we will take those now, and we'll call on you in the order that you raise your hand. Okay, Jen.
Good afternoon. Thank you. I know a lot of work went into this, so I just appreciate that commitment. I have a couple short questions and then a comment. I wanted to understand, it looked by the diagram that this is not going to go through rulemaking. So once the public comment period is over, I was wondering if there were steps after that for rulemaking or with CMS, or will these get implemented like right away? So I guess I was looking a little bit on the time frame for implementation was one question. And I was part of the session held last week on the therapy services. So, hopefully I can ask the question here, and I do plan to submit written comments. I noticed that some of the therapy codes that are getting cuts, significant cuts, happen to be codes used primarily in the brain injury clinics. And I'm talking the Maine Care 102 clinics, and there's 8 of them across the state of Maine. So with all of those codes together, most of which, except the assessment codes, getting cut, I wanted to comment that that would be especially devastating. To the point, I think we would be looking at having to reduce services for people with brain injury in the state of Maine. Neurorestorative, and I forgot to introduce myself. I apologize. My name is Jen Jello. I'm state director for Neurorestorative, and we have 3 neuro rehab clinics that use those service codes. And across the 3 clinics, we did some quick financials and budgeting, after last week's presentation, and we're looking at a $4.5 million cut. And that's in the face of looking at leases that are increasing, some of them by $4,000 a month. So there are a lot of things at play here in our economic climate, and I'm hopeful that we can influence not having cuts to that degree or at all. I think the intention of rate reform was to make sure that the services are being looked at on a regular basis, but not to go backwards. And that influences jobs, that influences our ability to serve people with brain injury in the state of Maine. So I just wanted to put out there, I appreciate a lot of work went into this, but this is absolutely devastating for us, and I'm really worried. I'll pause there. Any questions for me? I don't know if you can actually, I don't know if it can be a dialogue, but that was my concern.
Yeah, definitely appreciate the comment, Jen. I would ask, related to the Section 102 rates, please submit those in writing so that we can respond to them alongside the comment and response documents, and then also take your feedback into consideration when looking at what final rates should look like. Because again, what's presented through these last 3 sessions are only draft recommendations. We're hoping for the feedback to help inform considerations and change in those rates. In terms of implementation, I can say that we don't have an established implementation timeframe right now, and that is because of the various requirements that need to occur in order to implement rate changes. And that gets in part to what you were talking about, which is rulemaking, federal authorities, like all those things would need to happen in order to implement these changes. And because of how large this effort is, for budgetary reasons, appropriations, the need to do rulemaking, the federal authority requirements, we haven't been able to establish the timeline yet.
Thank you.
So just to give people a couple more minutes to think about that, if they do have some questions they'd want answered now. It was a lot of information, and I I understand it might take a minute to process all that. Also, if you don't want to raise your hand, you can type something into the Q&A and I will read it for you. But we'll give a couple of minutes to see if we can help anyone with any clarifying questions. And if not, remember, we're still here when you go in there. And if you have a lot of, then you get a question, you should be able to reach out through, you'll get a notice. My email seems to be out there for quite a few people already, so you can always email me, the rate reform box for your written comments. And I can't remember, did we clarify today about the BLS rates were Maine specific? And so those are not national rates from the Bureau of Labor Statistics, and they're not regional rates. Those are Maine specific rates, if that helps anyone when they're looking through any of the models or the appendixes.
And just a reminder, because I don't think that we touched on it today, but I know we did in the last presentation, but the appendix only contains the rate models that PCG developed. It does not contain anything that was benchmarked to Medicare, again, because that appendix is designed for what was a model developed by PCG. So if you're looking for rates and in the appendix and you're not seeing them, just refer back to the presentation and the detail will be included there.
So I guess we'll give it another minute and see if we have anyone who has a question to raise their hand or put something into the Q&A. And then if not, while you're thinking about that, if you have a question, I want to thank you again for participating today. And we really do need your feedback in order for this to be a successful process for everyone. Any last words from anybody else on the team?
If it would be helpful, we're happy to pull up any specific models or jump back to any slides that detail any of the rate changes. Feel free to call that out if that's helpful to prompt anyone with any questions or comments today. But otherwise, if folks are just eager to review the materials, as Jess mentioned, those will be posted on the website by end of day tomorrow. She's put the website and information into the chat. And, just thank you all for your participation today. And, throughout the start of this process, I know PCG did a lot of direct outreach to providers. So if you were involved in responding or providing details, we really appreciate all of that as well.
All right. Well, thank you, everybody. Have a great afternoon. I hope you can enjoy the sunshine and let us know how we can help. Thanks. Bye.